Hi, my name is Hiba, and today I'll be teaching you how to critically appraise a question of therapy. Specifically, we will be looking at the CODA trial as an example. Imagine that you are an epidemiologist at the largest hospital in Lagos, Nigeria. At the hospital, a significant number of appendectomies are performed as urgent surgeries. As a result, they are often disruptive to the surgical system. One day, you come across a research study coda discussing the use of antibiotics as a first line of treatment for acute appendicitis instead of surgery. If this is successfully implemented, it can greatly reduce the surgical load. But how do you know if using antibiotics is the right choice for your patient? This is where critical appraisal comes in. It is a process with a number of steps that will allow us to formulate a summary evidence based recommendation for our clinical practice. These steps include investigating the study's framework through PCOS, validity, importance, relevance, and worthiness. Firstly, we have to ask what is the clinical question in the case scenario, and what is the research question in the study specifically. We refer to PCOS, where P is the target or study population. Here, we define the characteristics that join the population. For example, what are the inclusion and exclusion criteria? In experimental studies, you will have the intervention, which is applied to the experimental group in the study. We want to assess the effects of this intervention. In observational studies, we look at the exposure of the participants and how it affects the outcome. The comparison group is the group that we want to compare against the experimental group to determine whether there was truly a difference. Some studies do not have a comparison group. The outcome is a measure we want to investigate and the result of either the intervention or exposure. We also want to look at the time frame of follow-up and the study design. So, in our study, we had consecutive English or Spanish-speaking adults in emergency departments who had appendicitis that had been confirmed on imaging. Ideally, we would want patients from all age groups since our hospitals have patients who are 50% children. The intervention group in our study are people who receive antibiotics, specifically intravenous formulation of at least 24 hours, followed by pills for a 10-day total course. This is an ideal intervention since this matches the intervention we want to apply to our case scenario. The comparison group are people who undergo appendectomy, and similarly, this is an ideal comparison group because it matches the comparison group in our own case scenario. So, for the outcomes, we have a primary outcome, which is the 30-day health status as assessed with the European Quality of Life 5 Dimensions or EQ5D for short. We also have secondary outcomes such as the patient-reported resolution of symptoms, as well as other many secondary outcomes. Now, ideally, we would also include the long-term complications in both groups. For example, what is the recurrence in the antibiotic group? The time frame for this study was 90-day follow-up, while ideally we would want, as stated before, long-term follow-up. The study design is a pragmatic, non-blinded, non-inferiority randomized controlled trial. Ideally, we would want a blinded study design. However, that may not be possible in the study specifically. Now, if you are unsure of the study design, you can follow this flowchart. Our study was an experimental study where random allocation was done. Therefore, it is a randomized controlled trial. It is also a therapy trial. Ideally, we would want to look at more high-quality evidence. For example, we would want to look for well-made systematic reviews and meta-analysis. Next up, we have validity. Here, we want to ask, is the study design and performance sufficient to adequately minimize the risk of bias? We are going to look at 5 different types of biases and how they can be minimized. The first one is selection. This includes randomization, which occurs at the start of the trial before the allocation of participants. This helps us avoid selection bias and avoid systematic differences between groups. It also accounts for known and unknown confounders. In our study, stratified randomization was performed. Now, stratified or block randomization poses a low risk of selection bias. Other ways to randomize is through a random number table or a computer random number generator. There are other non-ideal ways to randomize, which is the quasi-random, where we assign the treatment groups according to date of birth or day of visit, or even non-random assignment, where the clinician or participant have a choice on which group to be assigned to. Another form of selection bias is through allocation. Allocation occurs during the allocation of participants. No one should predict which group a participant is allocated to. This prevents changing the order or selecting who to treat specifically in order to get a certain result. Now, ideally, we would want to use central allocation or sequentially numbered sealed opaque envelopes. In our study, the allocation was performed through a data coordinating central or through central allocation. Finally, we also want to look at baseline characteristics. Baseline characteristics should match between the intervention group and the control group, which is the case for our own study. Proper randomization minimizes differences in baseline characteristics. However, we should also still check if there are any differences, which are usually shown in the first table in each article. Next up, we have performance bias. In our study, we need to have the blinding of participants and personnel. Non-blinding may cause issues such as different treatment of intervention groups, different participant expectations, and we also need to know exactly who was blinded and does it matter if there was no blinding. For our study, the study was non-blinded as it wasn't possible, and this may affect subjective outcomes such as the resolution of symptoms. For detection bias, we need the blinding of outcome assessors. We want to ask, were the measurements of all outcomes blinded? Subjective outcomes are usually more vulnerable to detection bias. For our study, again, it was not blinded as it wasn't possible, and therefore we may have some detection bias. Now, next up we have attrition bias, which is the incomplete outcome data. Attrition is loss to follow-up, withdrawals, or other missing data. This is not to be confused with the exclusions, which are available data that are not included in the report. We want to ask, are there enough missing data to meaningfully affect results? This can be answered through a fragility index or a sensitivity analysis. We also want to ask whether certain groups are more likely to have missing data than others. How was the data analyzed? Ideally, we would want to use an intention to treat analysis. This means that all participants were analyzed in the groups that they were randomized to, regardless of what happened during the study. Other ways to analyze data include the per-protocol analysis, where non-compliers are excluded from analysis. There is also the as-treated analysis, where non-compliers are moved between groups during analysis. And there is the imputation of missing values. For our study, an intention to treat analysis was performed for the primary outcome as well as a secondary per protocol analysis. Sensitivity analysis was performed using mice, and missing data and reasons were balanced for both groups as seen in Table 1. Now, for reporting bias, we have selective reporting. Statistically significant results are more likely to be reported. We need to compare the methods that are seen in the article to the results. Are all the outcomes, measures, and methods as reported in the protocol? For our study, a published protocol prior to the study was done. The results were reported as in the protocol. Subgroup analysis was done as mentioned in the protocol. So, you also want to ask whether there are any other sources of bias that stand out. What would be the effect of this bias? In the end, you want to give an overall rating about the validity of the results. For our study, there were a few biases, such as performance bias due to non-blinding, and so overall I will give it a light. Next up, we assess the importance of our study. Is the magnitude and precision of effect large enough to be considered clinically important? We want to ask, what are the reported measures of effect and precision? Are the outcomes continuous or discrete? We should consider both the primary outcome as well as any clinically relevant secondary outcomes. Those outcomes are preferably patient-oriented and will tell us about the health and function of the patient. We also need to consider both the full population and any subgroups. So, for continuous outcomes, you want to measure the control mean or the mean of the specific outcome you are looking at for the control group. Similarly, you want to measure the experimental mean. Your measure of effect will be the mean difference between the groups. You want to compare this mean to the minimal clinically important difference to see if the difference is actually meaningful. You get MCID through either literature, past studies, or professional recommendation. You also want the rate ratio, which is often reported in the studies. For our example, we calculated these measures for the EQ5D at 30 days. For discrete outcomes, we want to calculate the control event rate and the experimental event rate. If the intervention is beneficial, we will get the NNT or the number needed to treat. If it was harmful compared to the control measure, we will get the NNH or the number needed to harm. The NNT simply refers to the number of participants you need to treat in order to prevent one bad outcome. The NNH is the number of patients who must be treated with an intervention before one patient is harmed. If you get a negative NNT, that means the intervention is harmful, and therefore you actually get the NNH and vice versa. This also applies to calculating the absolute risk reduction and increase. For our study, we actually used a calculator where the link is provided here. You can also calculate them manually through these formulas. And don't forget the confidence intervals to measure the precision of our outcome measures. You need them for the mean difference, the absolute risk of reduction or increase, and the number needed to treat or harm. And remember that statistical significance does not equal clinical importance. So, how do treatment groups and subgroups compare? What is the size of effect, and is it clinically important? Are there any other important measures? For example, how many had undergone appendectomy in the antibiotic group? In our study, antibiotics were non-inferior to appendectomy through the EQ5D measure. For most other outcome measures, the appendectomy group had better outcomes. Participants with an appendicolith were at a higher risk for both appendectomy and complications than participants without an appendicolith. Next up, we have relevance. Here, the question is the evidence applicable and generalizable to the scenario at hand? We want to look at the precise two-wheel, which tells us about whether a clinical trial is considered explanatory or pragmatic. Explanatory studies tell us whether the intervention works under ideal conditions, meaning with the ideal highly selected group of people and through methods that are not typical in the general population. On the other hand, pragmatic studies show us whether the intervention works under usual conditions. If you are not sure whether a study is explanatory or pragmatic, try to answer the questions in this table to determine its type. Explanatory trials would have high internal validity, whereas pragmatic trials have high external validity. In order for a study to be more generalizable, it needs to have high external validity. Our study mentions that a pragmatic approach was used. However, the study was conducted among adults who were diagnosed with appendectis. The result of this study may not be generalized to the pediatric population. Remember that children consist of 50% of the patients in Nigeria. The study was also conducted in the US, which may have a differently equipped healthcare system than Nigeria. A trial of antibiotics followed by surgery eventually could end up as a financial burden on patients in Nigeria, and the study population included people who had a radiological diagnosis, so the study results cannot be applied to those who cannot undergo a radiological investigation. Finally, we want to assess worthiness. Are the benefits worth the risks, costs, and inconveniences? Here, we want to use case plots to visualize individualized risk and benefit scenarios. In this example, we have a case plot for the appendectomy group on the left and the antibiotics group on the right. Both of these represent the risk of hospitalization after index treatment by 90 days. Green faces represent the people who had the good outcome, while red faces represent the bad outcome. Green faces that are crossed out represent people who are harmed from the treatment that would otherwise have a good outcome. If the treatment changes their category from a bad outcome to a good one, we would see a yellow face. So, in our example, antibiotics caused harm to people who would otherwise have a good outcome if they were in the appendectomy group. We want to consider the clinically most important outcomes. Do the advantages outweigh the disadvantages? Do certain groups benefit more? While antibiotics were found to be non-inferior to appendectomy in our study, most secondary outcomes suggest that antibiotics may be harmful, especially to those who have an appendicolith. And therefore, to tie it together, for our recommendation, I think that the article itself is insufficient to change the practice in Lagos, but we can search for other evidence that supports and considers the population, including children, with long-term follow-up before changing the current policy. More knowledge on the hospital's demographics, such as the percentage of patients with appendicolith, is also required in order to reach valid conclusions. And that's how we critically appraise a study. Thank you for listening.